This is how mucosa inside, that's like a gut if you cut that cylinder and then open it up. It has a very special appearance, it's called cobblestone. If you need to remember the raspberry jelly for ulcerative colitis, then for Crohn's you need to remember cobblestone. Ooh, I have some stuff.
Stamps.
Caps.
Oh.
There's lots in my
You
pocket.
know you're a nurse when.
Metcalf. There's certain things, they put weight, they
Nope.
pull me down.
No meds in there, that's a good sign.
No, I don't. So, pathogens. Crohn's disease is another autoimmune condition that has chronic inflammation as a main pathophysiological problem there. And it affects small intestine, large intestine, sigmoid, and colon together, and rectum together. It can be more prominent in any area and less prominent in another any area. So complications include hemorrhage, severe malabsorption, malnourishment, debilitation, and sometimes cancer. So now think, if ulcerative colitis, patient has problem with colon, where reabsorption of fluid and electrolytes happen. With Crohn's, the problem is located everywhere in the gut, in the small and large intestine. And the patient has problem with absorption of all the nutrients, all the water, and all electrolytes. That's why here you see malabsorption and malnourishment. It is extremely rare to see overweight person with Crohn's disease. That could be if Crohn's started late and the person was already overweight when they developed this condition. On assessment, you see unintentional weight loss. Stool can be, it can look different based on where the lesions are located or acutely bleeding right now. So, if the bleed is similar to, in a location to ulcerative colitis, you will see bright blood. If the bleeding started somewhere in the small intestine, that blood will be processed and the stool will be dark. And then you also want to assess patient's stomach very precisely, and the patient will say that they have discomfort or don't pee. Sometimes it's more severe when you press on a certain part of the abdomen where the injury is located. Sometimes you palpate the mass, and it's not a tumor in this case, it's just thick, inflamed, edematous intestine. Especially in thin people, you can literally feel that sausage of the intestine. It feels like kielbasa. Sorry, but you literally can move it.
Oh. Ooh.
You're actually supposed to.
Yeah.
If you can get to it,
Get
with
to
some
it.
people, yes. Anemia is common. Because remember, everything has problem being absorbed. So vitamins absorb poorly. Iron absorbed poorly. Management, non-surgical and surgical. Non-surgical, medications that work against inflammation and suppress immune system. And these people need to have dietary consult and registered dietitian suggesting them how to eat and actually get some kind of nutrients in their body. Crohn's disease people people frequently end up with stomas also. Diverticulous. What?
It looks like an anglerfish.
Yeah, it kind of does.
Okay. There is not one.
But it kind of looks like that.
The mouth?
So, diverticula is something similar to the idea of appendix. It's kind of, or aneurysm, like a true aneurysm. It's a bulging of the whole wall out with the creation of like a pocket where the food can go into.
So they're not supposed to be there.
No, they're not. There are some special processes that large intestine has, but those are growth of the like a fat tissue underneath. They look like earrings, like the hanging earrings, and they look like fat within the very thin layer of connective tissue. They are alive and they're good. It's just one of the features of large intestine. And that's one of the things that you can look, okay, I see those earrings and I know it's large gut and not small gut. Those are protrusions of the whole wall. And the food can get stuck in there. And you may see symptoms similar to appendicitis, but anywhere where the colon is. And two conditions. Diverticulosis, osis, means you have this situation with diverticula, but they are not inflamed and not causing harm. Diverticulitis is the next step. It's when the problem is itis, diverticulitis, inflammation of these guys. Most likely, in most patients, they at least located here in the sigmoid, but they can be anywhere in the large.
Diverticula is there, but they're not inflamed. Is that what you said?
Diverticulosis
Okay. Is there? Okay.
and diverticulitis is when there's inflammation. Once nutrition / statistical fact. Patients who have diet poor in fiber and who have those diverticula are at risk for diverticulitis more. You normally, do you see my diverticula? You normally do not know whether you have it. I don't see mine either. You do not know whether you have it or not unless somebody did x-rays or CAT scan on you. So, in general public, those who eat less fiber are at risk for diverticulitis.
So just to clarify, this has nothing to do with Crohn's disease, right? We move
No,
on to
it's
the
a
next one.
condition.
Okay. Good. That's
They can rupture just like appendix, inflamed appendix. When there is just diverticulosis and those diverticula are present, patient might have no problems. They eat vegan food or vegetarian food and they're happy. They do not even know that they have the condition and they die from other cause. But if those diverticula get inflamed and patient develops diverticulitis, it's going to be abdominal pain, distension. They might come in the hospital with severe discomfort. If there is a rupture, you may see symptoms of peritonitis. For interventions, non-surgical management, we want, in most cases, patient to be NPO with NG tube on suction, which is low intermittent suction. Why don't you want to put it on continuous low?
So it doesn't get stuck.
It's too much.
So it doesn't like get stuck to their stomach.
Uh-huh. Because if you put on continuous suction, the end of NG tube will, like a leech, get connected to one specific area of the stomach and will suck that area in and can cause ulcer. So you want to suck, let go, suck, let go, and patient moves from side to side, so it can suck. Sometimes if it gets sucked to the wall of the stomach, well, in 5 seconds it will let go. It's not going to be ulcer. But if it's sucking for hours and days from the same spot, well, we're causing iatrogenic gastric ulcer. So never on the continuous suction. And one of the NCLEX questions regarding assessment of NG tubes. Remember that before auscultating the patient's lungs, you need to turn the suction off. Otherwise, you will hear not the breath sounds, but the suction sounds. What kind of ABG abnormality is your patient at risk for if they have NG tube on the suction?
Metabolic alkalosis?
Yes.
Yay!
Because they will be losing acid from their stomach. Very good. Surgical, they may end up with a stoma also. Celiac disease, I think we discussed that in 235. But one little recap slide. Multi-system autoimmune condition, the human is born with it, the human lives all their life with it. Chronic inflammation of small intestinal mucosa. So in this case, small intestine is a problem, it's not large. The problems are with absorption of everything that is absorbed in the small intestine, all the nutrients. And when can you see the beginning of the symptoms? As soon as the child is born?
After they start eating food.
After
Yeah.
they start food that can contain gluten. So with this condition, the main intervention would be gluten-free diet. And gotta help those parents, it's expensive.
Yeah.
It's devastatingly expensive. Parasites. Oh, where do we get parasites?
Raw meat.
They can come from water. If you come and decide to sip from the lake, uncooked meat,
Dirt.
Yeah.
dirt, if you eat dirt, yes, if you choose to eat dirt, fine.
People or
Other people
Mm.
with dirty hands,
Mm.
fish. While the fish that is caught in the fresh water especially dangerous, saltwater fish is not as dangerous. All right. Well, from where else? Meow.
Oh, yeah. They're a big one.
Yes, from cats and other pets. Absolutely. And I'm not talking about those pets that you would normally consider as pets. For example, pigeons can carry some parasitic infections. And it's not flu in this case. Guinea pigs can carry mites, which are scabies.
Chickens, lizards.
Yeah, all those beautiful pets that you like so much and you cuddle and swallow, they might have all beautiful stuff on their skin and their gut and everywhere. So they may enter your system and it's like, I want to be pet free.
You're still on vacation.
Yes. Main thing for GI parasites is hand washing. And I mean, you can add not sharing utensils, making sure that you wash food decently. If food is difficult to wash, like strawberries, then use baking soda to clean it up. If somebody else prepares food for you, make sure that that person washed their hands and they wash the foods. Do not drink random water, especially if you travel. Only bottled water.
I only drink bottled water, even at my house.
Yes. All right. Then we have one more PowerPoint left. Just one.
Dang, we're on a roll.
Huh?
We're on a roll.
Yeah.
I guess you're on a roll. I'm just part of the audience here.
Oh, participate. Oh, what's with the internet today?
It's not working so right.
Are we on the generator?
I don't think so.
I don't think we are.
Didn't get that much sleep.
That's true.
I think 98.
Megan did not come. It's the first time when I don't see Megan. Well, she's coming at 10.
I don't think she's coming today.
Yeah, I don't think she's coming.
She has an appointment.
Yeah, I don't see it with her drive and the ice. And
Okay. Oh, let's do it. Oh. He's not giving me a break. I can tell, but Andrew feels better.
he's like a superstar around here. He needs to come to the graduation.
He knows he is superstar. That's why he's the only child who does not come. And that reason actually is very altruistic. He said that he did not want to drag attention onto his persona from those who actually deserve
Oh,
attention during the graduation.
how selfless.
AKA just doesn't, he won't.
You got a good one.
He just does not want to come.
Right.
He can say it anyway. He can't say it back.
It's very demeaning.
He is a character, definitely. But it's Michael, my second one, who said that he's gonna have a whole room for mommy when mommy becomes a room. So he's gonna have mommy's mommy in the house.
Oh.
Yes. So I have in the future designated spot for my sarcophage. That's how I want to be.
Perfect.
So cholecystitis. This picture shows cholecystitis that is related to the gallstones. However, cholecystitis can be without gallstones. Also, this picture shows you where those gallstones can be. They can be either in the gallbladder or anywhere in the duct. And there's a reason why problems with bladder and the tracts related to the bladder and pancreatic problems are in one chapter. I would like you to keep those concepts together. It's like heart and lungs, gallbladder and pancreas. They are very close related. If there is problem with one, there is most likely problem with another. So symptoms are very frequently like interconnected. So cholecystitis, inflammation of the gallbladder, can be acute or chronic. Who is at risk? right? Those who eat McDonald's lunch, breakfast, and Wendy's for dinner.
Mhm.
That's cholecystitis. Also, those who like to have parties with eating. Up,
Thanksgiving every weekend, like
Yeah.
that kind of idea.
this kind of situations, yes, definitely, and alcohol.
Ooh.
Also, females are at high risk for cholecystitis. Remember that. That's high yield females. Well, most times symptom is abdominal pain. It can be quite intense, or it can be just dull and nagging. And the location of it is right upper quadrant. The patient may crawl in on the bed, like in a fetal position. Warmth, no, it's not cold pack, it's warm. So lab-wise, you're checking patient's white blood count, AST, LAT, LDH, bilirubin, and alkaline phosphatase. The key diagnostic method is ultrasound, please. That's gonna be first. X-ray is good when you see stones. On X-ray, you will most likely not see a thickened wall of gallbladder. It's just not as that precise. ERCP and MRCP. What's the difference?
What do they stand for? What do they stand for?
This is I'm not sure what E is. Endoscopic retrograde cholangiopancreatography. No, cholecystopancreatography. And if I tell you this, you will give me the
The answer.
exactly the answer. This is MRI study for the gallbladder and pancreas.
So one would be more invasive than the
So
other.
this one is invasive. That is, yep, exactly that. It's like scope in, and they study the ducts. And this one is MRI, but if the patient has a pacemaker, which one?
Oh, the endoscopy.
With the like a permanent pacemaker, we're kind of tied to this one because we cannot do MRI. If patient has metal rods in their thigh, in the leg bone, in one of the bones in the leg, then probably this is not a good option. So,
Is the MRCP what they call the hydro scan, or is that something different? The hydro scan? Different?
yeah,
Okay.
What does AST stand for?
ST.
AST, the laboratory, one of the labs?
Aspartate aminotransferase.
Okay.
It's one of the enzymes that liver produces.
Okay.
Your nursing diagnosis: acute persistent pain, weight loss. What do you want patients to eat when they have acute cholecystitis?
Low fatty food.
You want them at the beginning, you want them to eat nothing. So you're gonna give them rest. And then, yes, and no eggs and no spuds.
And no bloating.
No.
You're right. Treatment about how to eat after gallbladder was removed. What do you think?
Low fat.
Why?
They're gonna have a bad time.
Because.
They're gonna have diarrhea really bad.
Why?
Really fatty diarrhea, because the bile breaks down the fat, and
the bile, the bile
Uh-huh.
makes
Very-
it so
yes,
fat.
you getting it,
It
yes.
breaks down and be absorbed.
Mhm. So, does liver still produce bile?
Yes.
The liver still produces, liver always produces bile. That bile is drained into the, normally, in the gallbladder and stored there when there's a need. When we eat something with fat, that bile, because bile is the primary ingredient for the for mixing with the fatty foods and then digestion of those.
Emulsifier, that's what I was trying to
Yeah. So gallbladder squeezes, contracts, and puts that bile into the duodenum, and then the digestion of those fats happen. So in patients who lost their gallbladder, there is no storage. The bile keeps leaking. It leaks continuously. It's like the patient who does not have bladder, but we did not do anything about that. The urine will be leaking continuously. There is no way to put out by demand. That option is gone. So if we eat a lot of fatty foods, we will not get the bolus that comes out of gallbladder. We will have always like a little bit of bile leakage, constant, but there's not gonna be a sufficient amount to digest a bolus of fatty foods.
So would you want them to eat like smaller meals, like when they do
Yeah,
eat?
you want them to eat smaller meals, they should be easily digested. They should still have some fats, but those fats should be like distributed among all those meals and not like one protein meal, one fat meal, one carbohydrate meal. That is not appropriate anymore. Never was, but. What are the foods that contain a lot of fat? That most people eat here. You probably know better.
Hamburgers.
Hamburgers. Oh god. Those should be excluded.
Bacon.
Bacon.
Um,
Like healthy. What can they still eat? But they need to distribute.
Nuts.
Nuts.
Avocados.
Avocados.
Milk.
Uh-huh.
Okay.
Milk products, including butter. They can have some. They can have bread and butter.
chips? They're not healthy. Just a single chip.
Single chip is okay.
Everything in moderation.
Yeah, a chip.
A chip.
A chip and a ice chip. Yeah, so what else? Fish.
Oh, yeah.
Fish is a beautiful source of good fats and with omega-3 fatty acids. We cannot deny patient that pleasure and that healthy thing, but again, this needs to be in moderation. So have a fish day.
Fiddleheads have omega-3 too.
Huh?
Fiddleheads, they have omega-3 too.
Yeah?
I think they're the only vegetable that has omega-3. Yeah. Fun fact.
Then, next problem, acute pancreatitis. It's inflammation of pancreas. Altogether, pancreatitis can be acute and chronic. Acute one is a life-threatening emergency. And what is the problem with acute pancreatitis? There's a term that term out of digestion. Pancreas produces many things. It's like a super duper organ. So it creates, let me write this down. It creates amylase, protease, and lipase to digest nutrients. amylase for carbs, protease for proteins, and lipase for lipids. By the way, the word ase, the ending ase, ending like endings, means breaking down. So that one is going to break down carbs, that one breaking down proteins, and that one breaking down lipids.
Pancreas.
Good thing.
I'm trying.
And these enzymes are secreted, it's like exosecretory function. They are secreted and placed in ducts that then end up in the duodenum, normally. Also, pancreas secretes insulin and glucagon, right? But these guys go in the blood right away. They do not go in any ducts. So two different types of functioning. And ducts in pancreas, they look like a tree, just like anywhere else. So with acute pancreatitis, one of the major problems is with the delivery of these super active, chemically active enzymes into duodenum. There's a swelling of the organ, which is one of 5 cardinal signs of inflammation. Remember that? That inflames squishy pancreas, and it's very squishy. Almost like brain. The inflammation compresses the ducts, and chemically active enzymes got trapped within the ducts. They have no outflow. And guess what they start doing? Digesting, auto-digesting the pancreas that made them. Yeah, that's what auto-digestion is. And by auto-digesting, secondarily, they cause injury to those cells and islets of B cells that create insulin and A cells that create glucagon. So secondarily, the patient ends up with a problem with the endosecretory function, with insulin, with the blood sugar control. And that is the major complication. That is pretty much what I put, but you do not need to know this table. You need to know what I wrote. So, who is at risk? Those who have problem with cholecystitis and with the bile tracts. Remember I said those two come together? Gallbladder and pancreas, that's the time when they come together. Any trauma, like somebody took a vet to the back, acute pancreatitis. Those who do binge eating of bad stuff and binge drinking, it's called holiday pancreatitis.
Is it really?
Holiday, huh?
Is it really? That's awesome. Easy to remember.
Or after the procedure in the patients who had gallstones, and those gallstones were removed, like similar to lithotripsy. Sometimes we can take care of the gallstones the same way, like break them down. All right. Presentation of the patient. Acutest pain ever. Patient will describe their pain as, FYI, it's not on the slide, but remember that. belt-like pain. Belt.
Belt, okay.
And again, it will, everywhere where you see it, it will be in quotation marks. Belt-like pain. If not, in real life, in NCLEX it's always belt-like pain. If you see like regular floor patient, they may say, I have pain here. I feel like the pain in the abdomen, but it's close to my back inside. Like not superficial to the anterior part of the wall. Because pancreas is, again, it's very close to the back. It's behind. And then, because we always put cholecystitis and like biliary problems with pancreatic problems, patients may be jaundiced. Especially if the problem is related to drinking. So, your assessments. You want to check everything that has potential to be altered. Amylase, protease, lipase, insulin, patient blood sugar, bilirubins, LAT, white blood count, erythrocyte sedimentary rate. The first thing that the provider will order is abdominal ultrasound. However, it's not the gold standard for diagnosis of acute pancreatitis. The gold standard is contrast CT. Nursing diagnosis, severe pain and weight loss. What kind of diet would you recommend to the patient who has acute pancreatitis?
NPO.
NPO, correct. They need to starve for a little bit. What else do you need to do with them frequently? Blood sugar checks. Fig. What are your teachings if the patient survives acute pancreatitis?
Diet.
Mm-hmm.
What kind of diet?
Low
Low fat.
Mm-hmm.
You know what diet?
I am. It's like a fake statement, but I'm on a diet. But you know what? Any diet pretty much suggests that once a week you can have a cheat day. And on my cheat day, I eat half of the large breakfast bacon pizza. I'm on a diet. I follow your recommendations. So cheat days are not appropriate at this point anymore. Be very specific. It's not. You consistently every day cannot overeat stuff. What else should they? Absolutely zero. Never intake anymore.
Alcohol.
Yes, no alcohol or alcohol-containing things.
No red wine in your stew.
Yes, and no cognac in your coffee.
Cognac.
It's so.
It is.
It causes the opposite effect. It's like it's not coffee anymore.
No. No, it's
Don't
not.
you just sleep?
Well, alcohol is.
Oh, is it alcohol?
Yeah.
Cognac?
Yes.
It's 40%.
Yeah, it's not. It's no joke.
No, it's juice, apple juice.
It's to get rid of the shakes in the morning. Is what it's for.
Jeez.
Good Hennessy is good Hennessy.
Once in a blue moon, I'll have a glass of wine, half a glass of wine. Never finish it.
Good. Dry red wine, by the way, another NCLEX thing, not related to the subject, but still, has a substance. You need to know the name of that substance. Resveratrol. That is considered as heart healthy. Then the only place where you can get it naturally is dry red wine. that's why that specific type of wine is permitted in very mild to moderate amounts for cardiac health, and it is actually a part of Mediterranean diet. So, chronic pancreatitis. That is the situation when either patient did not finish their treatment of acute one completely, and the health was not restored to the original level, baseline, or maybe the patient never got to the point when they had acute situation, but they have like mild brewing of that chronic pancreatitis. What that is the slow progression of the same problem. So how to differentiate? By the clinical presentation, symptoms are not as prominent. And chronic also comes with exacerbations and remissions. You remember that any inflammation that lasts more than just a little bit of the time tends to leave scarring or overgrowth of connective tissue. And that connective tissue itself can cause problem with the outflow of pancreatic enzymes. And we're trapped back in the same corner. They will start auto-digesting, causing more inflammation, causing more injury, causing more problems with blood sugar regulation, and more scarring. So it's a vicious circle at this point. Few things. Chronic calcifying pancreatitis is when within the tissue of pancreas, calcifications grow. And they put pressure on the nearby tissue, and they also cause obstruction to some of the outflow ducts, and then the pancreatic juices cannot come out. Autoimmune talks for itself, and idiopathic pancreatitis is when we do not know what caused it. Patient is vegan. Patient never drinks any alcohol, does not use any substances, does not take any medications, and comes with pancreatitis. What's going on? And no problem with the gallbladder or ducts there. What happened? And no diabetes. What happened? We have no clue. And that's when you will diagnose idiopathic one. Out of the blue, with no predisposing factors that we could be aware of. Hereditary pancreatitis is that type of pancreatitis that can be quite frequently diagnosed in Asian population. And this is like idiopathic in Asians. And again, in the history, it will be a report that there's a patient who is like 43 years old, immigrated from one of the countries, like from China, for example, and never had any problems with their GI system, with pancreas, with gallbladder. Patient cooks at home, eats healthy food, never drinks, never smokes, nothing. But they report that their father died from pancreatic problems at the age of 50. What is that? Hereditary, autoimmune, not autoimmune, idiopathic. That's a picture of chronic calcifying pancreatitis. This is pancreas. And those white spots are calcifications. Let's take a little second of break and we'll